I would now like to demonstrate for you a generalized lumbar examination sequence. The lumbar spine can often be a difficult region to correctly diagnose due to the referral pain patterns associated with the lumbar spine as well as the sacroiliac joint. I would like to recommend the utilization of the treatment-based classification system that has been reported by Fritz et al. So, let's go back to the subjective examination. If the patient were to be reporting any myelopathic or radicular symptoms, we would have performed a lower quarter screen or any highly sensitive test to rule out the presence of lumbar radiculopathy prior to the initiation of the objective examination. My patient has not complained of any radicular pain or myelopathic pain, so I'll ask him to go ahead and please stand up for me and remove your shirt to expose the lumbar spine. If a patient refuses to remove their shirt, just go ahead and lift it up a little bit to expose the lumbar spine during the active physiological range of motion. But currently what I want to do is I just want to look at the big picture here for my patient. I'm looking at the curvature of the spine. I'm looking to see if the pelvis is anteriorly rotated or the low back is hyperlordotic. Go ahead and face the wall for me, please, Matt. All right, here I want to go ahead and just look at the pelvis alignment as well as the generalized lower extremity alignment. A clinician can utilize a gait analysis at this point to see if there might be any potential contribution from the lower extremity which may be causing or enhancing this patient's low back pain. I will not do so at this point, but I will ask my patient to go ahead and put their hands on the front of their legs, please, and bend all the way forward, try and touch the ground. All right, we're now entering active range of motion. Are you having any pain with that?
No pain.
No pain, so I'm going to provide some overpressure and try and rule out this region. Any pain?
No, the hamstrings are tight though.
Tight hamstrings, no pain in the low back. Go ahead and do me a favor, take one step forward, please. Thank you, sir. Put your hands on your hips and go ahead and bend backwards. Extend your low back. All right, any pain with that?
Yeah, that's uncomfortable.
Okay, the patient is complaining of pain with extension, so as opposed to performing overpressure, now what I'd like to do is ask him to repeat that motion and try and identify a centralization phenomenon. All right, go ahead and continue that repeated motion. Clinician can ask the patient to do this between 5 to 20 times. It's clinician preference. Are you getting worse or better with that repeated motion?
Yeah, it's getting worse.
Patient reports an increase in pain, so instead of having them do this 20 times, go ahead and just tell them to stop at this point. All right, so place your hands on your side for me, please, and go ahead and drag that hand on the side of your leg. And any pain?
No pain.
No pain, so I'm going to provide an overpressure. Any overpressure? Any pain?
No pain.
All right, to the other side, please. And again, any pain?
No pain.
No pain, so overpressure. There we go. How about that? Any pain with that?
Nope.
All right, great. Go ahead and sit down right here at the edge of the plinth and straddle it for me. What I'd like to perform is active range of motion for lumbar spine rotation. We'll ask our patient to go ahead and sit up as erect as possible. Go ahead and try and maximize the rotation at the lumbar spine. One hand over, one hand under, please. And go ahead and pick a side to rotate towards. Patient rotates, and any pain with that?
No pain.
No pain, so we're going to provide a little bit of overpressure here. Any pain with the overpressure?
No.
All right, go ahead and rotate to the other side for me, please. Here we go, and overpressure again. Any pain with that?
No pain.
All right, great. Go ahead and lie with your face down on the plinth for me with your head right here. So, woo, kicked my stool. All right, so if the patient were to have complained of pain with rotation, as a clinician, we're not going to want to ask our patient to perform repeated rotations in the lumbar spine due to the orientation of the zygohypophyseal joints being in the sagittal plane. Basically, if we ask them to repeat that motion, all we're going to be doing is jamming those joints together and flaring up our patient or making them more irritable. Our patient didn't complain of pain, so we did an overpressure, and now we're moving on to passive accessories. So what I want to do is I want to locate his Psis. Can I fold your pants just a hair here? Or your shorts, pardon me. Okay. Come down to the Psis. I'm going to go midline, identify S2. I'm going to go up one level to S1 as well as the sacral base. And now what I'm going to utilize is a Pisiform Grip, and I'm going to perform CPAs at L5. Assessing for patient pain. Is this your pain, sir?
Yeah, that's uncomfortable. You can call me Matt though.
Okay, Matt. Sorry about that. Is this getting better or worse as I repeat this motion?
Yeah, it's definitely getting worse.
Okay. Patient has complained of pain that's increasing with repeated motion at L5. What I next want to do is go up one level here, and we'll do L4. Try and see how the patient responds to the rest of these mobilizations in the lumbar spine. Any pain?
No, it's not that bad.
Okay. Up to L3. Any pain?
No, it's fine.
All right. L2, any pain?
No pain.
All right, we go up to L1, any pain?
No pain.
All right, so L5 CPAs is the only region that was irritable for our patient. So now what we're going to do is we're going to perform a UPA here on Matt's left at the L5S1 facet, utilizing our dummy thumb mobilization. And any pain with this?
No, that's fine.
All right, so we're going to go all the way up on his left side, the UPAs, asking for any pain. Tell me if you hurt when I press on you.
Nope.
Nothing? Okay. Now we're going to go down to the L5S1 facet again on the right side here. And we're going to assess for patient pain. Any pain with this?
Yeah, that kind of hurt.
Okay. Tell me if this gets better or worse as I repeat it.
Yeah, it's definitely getting worse.
Okay. So right-sided UPAs at L5S1 are making the patient worse with repeated motion. And we come up a level to L4. Anything there?
No, it's okay.
Nothing there. How about here?
That's fine.
Okay, and we just want to go ahead and finish our passive accessories in the lumbar spine just to make sure that we don't miss any referred pain that might be from multiple segments in the lumbar spine. All right then, so currently my patient falls within the stabilization group for the treatment-based classification. To truly identify this patient within that group, what we have to do now is rule out the presence of instability that might be due to the sacroiliac joint. So I want to perform Laslett et al.'s clinical prediction rule to identify sacroiliac joint instability. I'll ask my patient to roll supine for me, please, on your back. And the first test I'll be performing is the thigh thrust test for the SIJ. So I'm going to bring the knee up here, 90 degrees of hip flexion. I'm going to roll the patient towards me, and I'm going to stabilize the sacrum with my hand, and I'm going to roll the patient right back over, and I'm going to apply an axial load right through the femur. Pardon me, this is not an axial load, this is anterior to posterior force at the SIJ. We're going to hold for 30 seconds, assess for patient symptoms, any pain?
No pain.
Okay, 30 seconds have passed, so I'm going to provide small oscillations. Any pain with this?
Still no pain.
Still no pain. All right then. So the next test is going to be distraction. So what we want to do is we're going to find the ASISs, we're going to place our hands on the bilateral ASISs and perform a distraction force. Any pain?
No, that's fine.
All right, again hold for 30 seconds and then reassess. Any pain?
No pain.
Okay, patient still complains of no pain. So we need to get 2 out of 4 to rule in the SIJ. We've got 2 negatives and there's 2 tests left as a possibility. So we're going to have to go to the compression test. Roll to your left side, please. Go ahead and scoot towards me here a little bit. We're going to identify the iliac crest, and what we're going to do is we're going to provide a compressive force for about 30 seconds and see if the patient reports any pain.
No pain.
No pain. Tick tock, tick tock. 30 seconds have passed. Small oscillations. Any pain?
No pain.
Patient complains of no pain. All right, so the first 3 tests out of 4 are negative. Therefore, the patient does not suffer from SIJ instability and is falling within the stabilization treatment-based classification group. And that is how you perform a lumbar examination.